Welcome. Just a couple of items before we start. We've got a lot to cover today, and we've slipped in an extra item about digital process funding, excuse me, which we believe we've got a mixed message because Paul is coming to talk to us about the ending of the funding, but a different government operator has contacted us about more funding for digitisation. So it's not exactly clear to us exactly what's happening. What I would say is that domiciliary care providers have been poor at taking up the funding offered. If you don't have a digital business or you're not digitally focused, you won't have a business in a year or so's time. So please do take up any advantage, any of these benefits that you can. And John will also be joining us to talk about the government funding through DH&SC. So that again is useful to you. And again, we'd urge everybody to take that up. And I guess it's just possible that someone from Skills for Care will come along and talk about what's going on with them. And again, do look at the newsletters that you get from Skills for Care, etc., etc. And just harking back to a point that was raised at the previous meeting, if you have not paid your fees to CQC because you are not able to pay your fees, please make sure that you contact CQC to say that you can't get to pay your fees. There's a communication breakdown between CQC and the NHS department that actually handles the money for CQC. And it may just be a simple Microsoft issue. Don't you love technology? And it may be more problematic, but we're aware that some people haven't paid their fees for some years. You are not likely to be excluded, but you may lose your registration. So please make sure that people actually know, i.e. CQC know. If you've got a problem, let us know. And also we're hearing quite a lot of complaints about fees, local authorities trying to force fees down, trying to force people onto direct payments. If you are able to let us know, it's useful for us, so please do. Anyway, without more ado, Dudley, are you available for a few quick words, or I will pass straight on to Dr. Mark Wareing? Okay, Dudley's...
I am actually here. Sorry, I'm just trying to get people the passcode. So thank you very much, everyone. And apologies. Don't just love technology. Never work with animals, kids, and technology, but it does come around now and again.
Dudley, yes.
Before
you carry on, my dear, I'm sorry to interrupt you. I never do this normally, but my name is Aoife. It's just what Peter said. Peter, will you be able to send us the link to everything you've mentioned so far in your introduction, particularly about sort of like links to government funds, and also and also the named individual we need to speak to if we've got an issue about fees with local authorities? Thank you. Sorry. I'm first time here, so already been shared and discussed earlier.
Local authorities work on a divide and rule approach. So it's a different contact for each local authority, and there will be a denial of responsibility. So you'll have the social work department will pass it off to commissioning say it's not their responsibility, it's social work. So it's about building up a contact list. But if you've got an issue with a particular local authority, either contact myself or Dudley after the meeting, send us an email, give us a bell, and we'll talk it through.
Yeah, thank you very much for that. And please do, whilst this session is going on, please do add anything to the chat, and we will try our best to answer as best as possible. We know it's a full meeting and there's lots going on in the sector. We've been, Lcas have been kindly running a various array of events, some with overseas recruitment or sponsored workers. We're also dealing with things around fees. Peter has been speaking to CQC. and we're also part of the CAA, and just to be aware that we're trying to make inroads in working with the local government, the new government, and seeing how best we can go forward with it as well. We also know there's a raft of changes at CQC. Every time we turn on the news, someone seems to be going. So we will keep you up to date as much as possible. And also around training and funding, we know lots of people are talking about that. We know local authorities, things are different up and down the country as well. So we will do our best, especially we're more London-based, to share with you the information. As you can imagine, there's so many different local authorities in London. It keeps me and Peter up most of the night as well. But other than that, please go onto the website. People share the information from that. And we will do our best as well to, as you said, answer queries or put you in the right direction where possible. So apart from that, I will leave it in your hands, Peter, whilst I hope to try and get another people in.
Okay, thanks. I was actually jumping to CQC. I was supposed to be having a meeting with James Burrows this morning, but that's been postponed for the second time. So whether it'll ever take place, who knows? Right, Dr. Wareing, sir, over to you.
Thank you very much, Peter and Dudley. It's lovely to be here again. Greetings from Brunel University of London. I came to this meeting a little while ago to talk a little bit about practice education opportunities for our nursing and occupational therapy students within social care. We are really committed at Brunel University of London to promoting social care as a first career destination for our occupational therapists and also our nurses. And we're really excited that we've now got 2 members of this group, 2 representatives of social care providers within London who step forward to provide placements for our students. And we're also working with Surrey ICB and Surrey Care Social Care Association as well to really promote social care as an exciting place to work for nurses and occupational therapists. So again, I suppose I'm here really just to explain a little bit what we're interested in. My vision really is that we create a network of different placements and practice education experiences. And the reason why I think it's of interest to you as colleagues within social care is that if our students get an experience, obviously it gives them insight into social care, but also there are opportunities for you as social care providers to maybe consider employing some of our students on a part-time basis because they're keen for employment within the sector. But also if you provide a practice education experience or a placement for our students, then we can actually pay you. So we have a student tariff of £130 per week, which we can make available for you. And obviously, the more placements, the more students that you provide, the greater that payment will be. So it's a way really of introducing learners into your services, providing them with really interesting transformational learning experiences, but most importantly, involving them in care and seeing really how students can make a difference, particularly, for example, if you don't have an occupational therapist or a nurse in your service. This is a really cost-effective, cheap and low-risk opportunity for you to introduce nursing or occupational therapy within your services, and also provide students with an insight into the business side, the contractual side, the service side of what you do in terms of social care. So I think that's kind of it in a nutshell. I've got a brand new flyer, which I'll try and pop into the chat. And if I can't do that, I'll email it to Peter to circulate. But I'll certainly put my contact details in the chat, and do contact me. I'm happy to come and visit you and meet with you to talk about practice education experiences further. And also come and join us at Brunel University of London at our Uxbridge campus. We'd be delighted for you to come and meet with our students to talk to them about social care opportunities and the exciting world of social care. Thank you, Peter.
Thank you, Mark. Take myself off mute. We can only urge people to take these routes to support their staff and to build greater links with training, with education facilities. It has to be the way forward. And Mark Wareing has got a lot of experience in this area and has proved, to be good at communicating with people, to get people what they need. And areas like occupational therapy, getting occupational therapists into social care, it tucks right into the areas such as staff wellbeing, looking after your staff. Many people will have seen the report recently in The Guardian about over 10 million people in the workforce don't have any option to staff support, to wellbeing within their workplace. It's a slightly skewed report, but it does make a good point. So, if you've got any queries, please talk to Mark, invite him over, and let's see what we can do to build support. Now then, is Mr. Buttle with us? Okay, I don't think John has yet arrived, and neither. Oh, John is here.
I was just muting, keeping my camera off because there's a lot of people, and I know it affects the wavelength.
Great. Good morning, John. Jonathan from Social Works and is our resident expert on the Department of Health and Social Care training funding.
I don't know about residential expert. I think it's more of a case that I know slightly more than a lot of people, but that's about as far as it goes. And during my contact with the help desk at the new learning development support scheme, I'm not sure that some of them are experts either, to be honest. Now, have I got sharing so I can put the slides up, or do you want me to just run through more quickly? Because I know you're pressed for time. You're on mute, Peter.
Sorry, John, you are our co-host, so you can share.
Oh, lovely. Okay, right. Let's see. Dun, dun, dun. Don't worry, all of these slides, I believe, are going to be shown and kind of spread about later. I'll cut back on the history, but the history is interesting because back in April, it was announced there was going to be 150 million quid going into social care funding, social care training. A lot of that, or a fair chunk of that, was going to be on a new level 2 care certificate, and the rest was to help really boost the social care workforce. And we were all working towards that new scheme, which was starting over summer, they said, but replacing the WDF from April the 1st. And then what happened was we had an election called, everything went into purdah for a good kind of 6 weeks. And then shortly afterwards, we had an announcement that no, we're not going ahead with this funding. There was a bit of a campaign. I got meetings with Stephen Kinnock's number 2. And then we found out that, yes, they were going ahead with funding, but they were going to be doing it at the same level as the Workforce Development Fund for the previous year. So that's roughly £12 million available for the country. There is a Workforce Development Fund legacy fund, which is running until the end of 2025. But that is only for people who started on courses before the 31st of March this year. So it's a kind of dovetail to make sure that people don't lose out, especially on the level 2 diploma, because the level 2 diploma is under review at the moment and is not being funded during this financial year, and we don't know whether it will be funded for the next one either. So if you have any learners that are currently on a level 2 diploma, please make sure that they finish, well, ideally before the 1st of March next year, so that people have time to do all the marking and get the certificates done and for you to get the claims in. So we have a new funding system which is taking over for all social care training, and this is being run directly from the Department of Health. So it's not coming via Skills for Care. It's not involving any of the old partnerships that we've been used to working to. And it is being done so that employers claim the money directly. It funds qualifications and certain training courses. Much like the WDF, there is a list on their website which tells you what is and what is not funded. Well, it tells you what is funded and by default what is not funded. It is still currently funding courses such as Lead to Succeed and a lot of the programs that Skills for Care are running in terms of, you know, how to prepare for inspection, how to, you know, the various modules they've got for registered managers. They are all still available for funding for this financial year at least. We are expecting the budget for 25-26 to be announced following the overall budget. And the Department of Health have told me that it'll probably take about a month or so after the 30th of October budget or 31st of October budget for them to announce that. And then they are still planning on shifting towards a 3-year funding period going forward from there, which is, for I think most people in the sector, something we're really looking forward to, having had, you know, year by year and then money not being released until halfway through the year for the last, what, 4-5 years, if not longer than that. So that will be a good thing. This new funding is valid for all learners who are starting from the 1st of April. As I said before, anyone who started before then, you should be putting a direct claim into Skills for Care for that last final year of the Workforce Development Fund. There are some interesting things with the new funding, one of which is the very, very welcome thing that you can now get 60% of the fundable money for a qualification funded up front. So the minute a learner, for example, starts on a diploma, the employer can claim 60% of that claim value from day one, which is a big, big change to how Skills for Care have been running it for years, where you can't claim a penny until everyone's finished. You then claim the remaining 40% when everyone's done under the new LDSS scheme. There is an interesting bit in there that if a learner finishes the course but doesn't qualify, you can still claim that 40% back. But nobody that I speak to at the Department of Health seems that sure exactly what that means in practice. I said, does that mean that as a learning provider, if somebody attends all of the sessions but just can't finish the final workbook, and we evidence that with a letter that the employer can claim, and they said yes, but I won't know whether that is true until I actually test it. It seems a little bit unsure at the moment. As with the Workforce Development Fund, there are no restrictions on nationality. All that the LDSS requires is that an employee is legally employed in the UK for you to be able to claim funding for their training. You will have to provide a UK national insurance number, which again is a change from the old WDF. Now, to get eligible for the funding, there is an onboarding process, which is it's a word I don't like, but that's the one they keep using, whereby you contact them and there's a link there where you do a very short survey which tells them basic information about you as an employer. The Department of Health will then contact you, and do look out for that coming from a phone number you don't recognise. I know some people have missed it because they didn't recognise the number. It comes up as from North Shields or somewhere like that, and I think people just don't answer because they think it's going to be somebody selling you double glazing or wanting to replace your gas supplier or something. So when you do fill in that form, do look out for a phone call from a number you don't recognize. They will then make a telephone appointment with you and give you another slightly more detailed form to fill in. From most people I know that have gone through this process, myself included, it is relatively straightforward. And at the end of that telephone session, you will be equipped with access to the claims portal and with your own kind of verifier two-way authentication app on your telephone. And just as a proviso, do remember the funding is paid to you and not to the learning provider. One of the big changes that they have made is that to claim the funding, you will have to evidence having paid the training provider the course fees in advance, which is nothing to do with me. I didn't ask for this, but I must say, from a learning provider point of view, it is quite a nice welcome change, because as you know, people will claim money and then things happen and we'll be kind of sending gentle little nudges for months afterwards. So for this one, you will have to evidence having paid a learning provider first. So with us, for example, you sign up learners, we charge you or we invoice you for the fee content. And once you've paid that, I would issue a paid receipt and you use that as part of the claims process. And I do know that this has been running fairly smoothly. We've been working with employers now who have been claiming a backlog of training that we've been doing since April. And I've not had, well, I've had one person say they had a problem, and it turned out that was because they hadn't submitted both of the invoices to say that we'd been paid. So that's roughly how it works. You will still need to be signed up with the ASC WDS, what used to be the NMDS system, to log details about your organization and about your staff in order to be eligible for this, in exactly the same way as you used to have to do to be eligible for Skills for Care funding. Eligible courses, again, follow the link. They mirror what the WDF funded last year. And they are adding one or two new ones as and when they go along. So it is worth refreshing and checking to see when that page was last updated. There are a couple of things to be aware of. As I've mentioned, the level 2 diploma is not being funded through the LDSS. The other thing is, if you are a provider that has a lot of learners on apprenticeship programs are not funded through the LDSS anymore either. So whereas I know in the past you'd put a learner on an apprenticeship, the apprenticeship is paid for through the Skills Funding Agency plus an employer contribution, and at the end of the course you would be able to claim back from Skills for Care as well for that learner. They're not doing that from now on. So please be aware, if you're signing people onto a new apprenticeship course, you will not get any extra money on top of the course being paid for. How to start training with us? I mean, I should point out that other learning providers are available, but you know, I suspect very similar systems. To enroll learners with us, you simply send us their details, the course that you'd like to be on, and who from your office you would like to have copied in at all levels of communication. We ask that you check and run through with us the commitments and guidelines that you and the learners need to follow. We then send out enrollment links. And again, just a reminder that you will need to evidence paying us first in order to be able to claim 60% of that course fee back up front. For most of our courses are via Zoom with electronic workbooks and remote tutor support. So you will need to make sure that learners have a computer, a laptop or a tablet. Mobile phones still aren't really up there as good enough. in terms of getting workbooks done and stuff. In terms of the courses we run, the large bread and butter one we do is for new staff. We use the funding that's available for the level 2 certificate in medication to subsidize doing care certificate knowledge. We have cohorts running every week, start Thursday, Friday, and finish the following Monday, Tuesday. And we've been doing that for years now, and we've been doing it remotely ever since COVID first struck and put thousands of people through. And that works really, really well. So if you've got new staff, that's a great way of doing it. Because our cohorts are open, if you've got 1 or 2 people, that's fine. If you've got more than that, that's fine as well. And that is as flexible as your recruitment needs. For managers, we do all of the Skills for Care endorsed programs. We're a Skills for Care endorsed provider. We're not sure what's happening to Skills for Care endorsement going forward, but I don't know whether somebody from Skills for Care is here to kind of tell us, but I know our endorsement is valid until Christmas. And hopefully we'll find out what we need to do before that. Again, all of these courses are run virtually. They have the added advantage that your learners and yourselves, if you decide to go, you're there with managers from lots and lots of different organizations, which really adds to the learning experience in our experience. We also do a couple of specialist courses. We do the level 2 awareness and dementia, and we do an introduction to autistic spectrum conditions. The autism course, I should point out, I would recommend that for senior staff and managers. It's a brilliant course, but it is really quite in depth, and the homework commitment for that is expected to be in quite a lot more detail and with quite a lot more thought than for some of the others. We do all of the diplomas, although I should say with the exception of the level 2 now, with LDS funding plus an employer contribution. And again, we normally do that through a series of 4 workshops online, and then of course the remote visits and observations. There is, as you've probably heard, a new level 2 award in adult social care. It is it's basically RQF level 2 version of the care certificate. And we recommend this for nearly new staff. It doesn't stop you doing the care certificate non-regulated for your new staff, and that is still the recommendation. But I would say that if you've got people who you might have been looking at for a level 2 diploma, or who have been with you for 6 months or so, and you feel are committed to you as a company, and you're committed to them in terms of the hours you're giving, I would strongly, strongly recommend that you think about putting staff on this. I think, at least in the short to medium term, this will be a replacement of the level 2 diploma and a lot more accessible for a greater number of staff. It's also incredibly well funded through the LDSS, so there's no need, we don't need to charge an employer or learner contribution for that. We just do it for the funding that's available. And for trainers to match in with that, because there will be an enhanced need through the demand for people doing the level 2 care certificate, RQF, we are now setting up classes as well, so that if you want to send some of your staff to do the level 3 award in training and education, basically the assessor's award that you need to assess RQF qualifications, we're just starting to run programs for that as well. The idea with that is that if we have a number of your students doing the level 2 certificate for, the level 2 care certificate, we would be able to train up maybe 1 or 2 of your staff, or more if you're a big employer, so that you under our mentorship can do the workplace observations. We would pay you for the time that staff are doing that. So it gives you a small income stream. It gives us a much easier way of coping with the demand. Because one of the problems that DOH flagged when all of the new funding was announced in April was that there are just not enough assessors in the sector. So this is part and parcel of the way of trying to combat that. Again, all of the important links are there and will be shared as this gets sent out. And I think apart from that, it's just a question of any questions, really. I know I've rushed through it a little bit because I know we're pushed for time.
Thanks, John. I think there's a few questions in the chat about what can be funded. So if we could just flick into that. Train the trainer for BLS and manual handling.
No. I say no, you can. The level 3 assessors award won't do you as train the trainer in some respects for that. But we're planning to be looking at moving people on so that we're offering what used to be the Petals and Dettles, the 2 different teaching awards, so that there'll be progression to do that. But at the moment, there's not funding available for a straight train the trainer course that's non-regulated.
Can you do PMVA or ILS, whatever they may be?
We don't. There is limited funding available for that. And on the LDSS site and the Skills for Care site, you will find a link to verified organisations that can offer that and are eligible for the funding. You just have to be very sure that you're very careful that you are picking those recommended providers. Otherwise, you won't be able to get the funding for it.
Thank you. Any other questions for John? We'll share the slides and also the contact, and John will put his contact details in the chat anyway, so you can talk to him, contact him, no problem.
Can I just make one point before you move on, Peter? As John mentioned, you will be able to reclaim the money back. People always seem to forget that, regardless in paying John up front or whichever organization, you will be getting the money back. So always to make sure whoever you're going through, make sure you follow the procedure and understand the process. John, I'm sure, will kindly tell you how to get your money back very quickly. The other area that people are, just a reminder, is that you can use this money for your organization. So that means you can train your overseas or sponsored workers, and people actually forget that there is not much funding for that workforce. I know there's various training courses available. I think John will put that link there for the available courses that you can train or go under, and you can actually fulfill getting some of those sponsored workers as well as other staff to be trained with this funding. So it's hugely important, and as John mentioned, please do make the most of it. Even though 12 million sounds like a lot, it can go fairly quickly. And before, with Skills for Care, the government wanted people to take it up. The less people who took it up meant the less money would be available in the next financial year. So please, please, please do try and get as much training in. And I don't usually get the chance to say, grab the money whilst you can. It's not usual for that to happen. But go ahead.
Yes, sorry, it's just a quick point. There was always a problem with the old WDF in that if you were with a partnership, you'd get to a time of the year where the partnership would say, we've got no more money left. And you would be, we always managed to get around it, but you would have a couple of months where you're struggling to know whether you're going to get the money back for training that you've done. With the new LDSS, there doesn't seem to be that restriction. So they have said that they are limiting funding to 440,000 per employer. So I don't think anyone is going to have a problem maxing out the claims. So that's good news, really. There's more available per employer, and there's less stress about whether there's going to be money left to fund learners later in the year.
Thanks for that, John. I think all information will be on the website, and watch the space. I'm sure John will keep updating us on various elements around training as it continues to go on as well. Thanks again. I'm not sure if Paul Harper is in.
I've seen Paul join, yeah.
Okay, no problem. Well, then we have the pleasure, unless you want to say anything else, Other than that, I think we have the pleasure of having Mick Feather. I know we've spoken about an ex-CQC inspector, so please no heckling. He now works with Citation, but what he does is try and analyze what's happening and shares his insights as well. So please, I will give the floor to Mick to take over. It's all yours.
Hang on. We're going to do, sorry, Mick, we're going to quickly do Mr. Harper.
Oh, he's in.
Yes,
Oh.
I'm here, Dudley, and with my colleague Ryan as well. So yeah, we're going to do a quick digital update. Do you have our slides, or do you want me to share slides?
I've got the slides. Hang on, hang on.
Start, Peter. Thank you. Makes it so much easier.
Apologies, everyone. Sorry, Mick. I think I didn't hear Peter say that you were in the building, Paul.
No
so
problem. Apologies.
Just let me find the slides. I know I've got them.
Yeah, thank you. Yeah, we just wanted to come in and do a bit of an update on sort of 3 or 4 key areas. But the most important thing was well, they're all important, they're all really useful and will benefit you guys. But yeah, if you just want to click on to the next slide. Thank you, Peter. I know we've only got 5 minutes or so. So digital social care records. The NHS has funding currently. In fact, we've had it over the last 3 years. This is the final year of the programme. If you are drowning in paper, if you're using a paper care record, we can help you move to a digital social care record. There's an NHS assured list, a whole range of providers. I think there's about 20 on the list, and I'm talking to care homes as well as domiciliary care, supported living. If you are providing adult social care, if you're CQC registered, and if your care plan is paper, we can provide you a grant of up to £10,000 to help you move to a digital social care record. There's a fairly swift process. Don't need a business case, expression of interest, anything like that. If you are providing services in South West London, if you've got a South West London address, you're CQC registered, we can help you out with a grant. It's a one-off grant to try and cover the first year costs with a digital social care record. Now, this is the last year of the programme. We've already met our target with NHS England for both the numbers of services and the numbers of beds covered by a digital social care record, but we've got funding that will take us up to the end of March. So just get in touch. Next slide, please, Peter. Just provides a bit more detail in terms of the digital social care record. So there is an NHS assured solutions list. It's a case of picking from that list. We can absolutely help you with that selection, with demonstrations. And as I say, this money is available for any CQC registered adult social care services. If I say that 85% of care homes have already got this in place, many are mobilising at the moment, and about 77% of domiciliary care already have this in place. But there are probably about 120, 130 providers out there that are currently using paper, and we can help you move to that digital social care record with a grant of up to £10,000. I'm going to pass over to my colleague Ryan, I think he's on the call, just to do an update around London shared care records and the universal care plan. So next slide, please, Peter.
Just to quickly touch on the London Care Record, it's a hub. It's part of the shared care record. It's a hub where all the clinical updates come into from the GPs, hospitals, and other medical settings that care homes now can get a view only of this. So if their resident goes to hospital, they can see all the test results, discharge summary, future appointments, and what have you in there. All the care plans, ambulance notes are in there as well. And so it's just seamless provision of care and more information about future residents who are joining the care home. They can get to see their past medical history. It's a phased rollout to care homes using PCS, the person-centered software system, and then care homes using the Nourish system will follow hopefully soon in the next month or two. And then I saw the question, it's across London for now with a view of it becoming a shared care record in other areas outside of London. I think there are pockets outside of London where it's happening for now. And so Nourish homes are next, and then it'll be Care Vision, and they'll roll it out to other systems. And then there's talk of it being rolled out to domiciliary care services, but that's not available yet. And then the Universal Care Plan we're targeting care homes in South West London to set up their own care plans for their residents with their wishes and support wishes and care to be viewed by GPs, hospitals through the London Care Record. So it's widely viewed, and care homes can set this up themselves. Next slide, please. And Paul, shall I just touch on the
DSPT, absolutely, Carol.
Yes,
Yep.
so the data security, some of you may be aware, it's a online self-assessment just to measure your performance against the data security standards. But it is necessary if you're going to access NHS patient data. And our team can help care homes and domiciliary services go through this. And we find almost every time there's a benefit to the service. They find tips about security awareness. Thank you. Next slide, please.
And I think with DSPT, particularly for, I mean, I think about it, 95% of services have got it. For domiciliary services, chances are you've already got all of the evidence items. So in a call lasting probably, I don't know, an hour, 90 minutes, you can get through the standards. It is a self-assessment and get to standards met. So we've got a fairly slick process if you haven't already got DSPT in place. So yeah, next slide, please, Peter. It's just our get in touch slide. So get to us. I'll also drop my email into the chat as well, but that's our shared mailbox. So if you need any more information about shared care records, if you are drowning in paper and want to make that shift to a digital social care record, let us know on that address. And if you need a hand with DSPT, we can link you up with one of our team, and we've got a fairly slick process to get you to standards met on DSPT. So yeah, happy to take any questions. Otherwise, Peter, we knew we only had sort of 5-6 minutes here, but no, thank you for the time at Lcas. Thank you.
Just a quick question. I know people have asked a question. You did say as well that you are not the only person. There are other pockets in London who are also supplying it. I'm not sure who would they need to contact potentially in other parts if need be.
If you come through to me, I'll redirect you. Because yes, at the moment, I think every ICB is live with the funding program for digital social care records. So come through to me and I'll point you in the right direction. That's probably easier.
Thanks, Dad.
Yeah.
Thank you. And we can't stress enough that, digitization is the way forward. And if you aren't digitally focused, I suspect that within the next 12 or 18 months, you won't be in existence, basically.
We really don't know what next year's funding programme will be. All we know is that we're funded up till March. Some ICBs may be closing the offer early. We in South West London aren't. We're going to keep going up to the wire.
Great. Thank you very much.
Thanks.
Mr. Feather.
Yeah, thank you. Thanks again. I think before we bring in Mick, we've given out as much as we can, and you don't usually see that when you come to many social care meetings. So please do grab what you can as well. And other than that, I think finally, Mick, here's your chance. Thanks again.
Thank you.
No problem. Excellent. Go. So Rosie, my wonderful assistant on this, has probably got some slides, and also probably the first thing we're going to do is would it be useful for me to give you a bit of an overview about Penny Dash's report? Kind of. Would that be useful?
Yeah. Yeah.
So I mean, really for me, I mean, I'm sort of in between. Everything's to say that the CQC are in a bit of a mess is being kind. I mean, what I would say to you is if you're having a bad day, first of all, I need to thank all of you in adult social care, the brilliant job that you do, most important job there is in this country. If you're having a bad day and you're feeling that everything's not going well and things are not great, have a look at Dr. Penny Dash's report about the CQC, because you'll feel an awful lot better. The reason being is that there's just so much that's wrong. If you want the detail of it, you can look at it on the CQC website. But just to give you a bit of a sort of update. So in July, there's an interim report by Penny Dash to see what operationally how CQC were going. Last week, she actually provided the full report just to give you some sort of idea about the issues. I mean, one of their issues is that they've got a culture problem. I mean, to be honest, that's quite funny, the fact that they're going to come to your service and actually look at your culture to see whether you've got a closed culture, and their own culture's not great. But anyway, the 5 issues that she's already had as findings, if you look at the sort of summary, their operational performance is not great. So if you look at some of the figures, so in, for example, 2019, 2020, they actually did 16,000 inspections. In 23, 24, they only did 7,000. So, I mean, that's giving you some sort of idea about why that's a problem. Any of you that have been involved in the portal, the good old provider portal, I mean, they've nicely put it in the report as significant challenges. So next time something doesn't work, say that you're having significant challenges, because that seems to be the word rather than the fact that it just doesn't work. What's the third thing? Considerable loss of credibility. The reason why I'm going to talk to you is about the fact that when the regulator is particularly kind of at a weak point, that makes you guys stronger. And I think it makes you stronger because it's the fact of you guys know what you're doing. The regulator is having a bit of a problem. Concerns around the single assessment framework. So that's the thing that I'm going to show in a minute, just to give you an idea about what on earth all that chat is all about, why that's a reality and why it's a problem. And then the fifth point that she raises is that there's a lack of clarity regarding how ratings are calculated. Usually I would just say, have your inspection, wait for your rating, there you go. I think this is an opportunity for you to be aware of what the issues are regarding the single assessment framework, and for you to be, you know, confident and competent about actually talking to the inspector about what they're going to look at and what they're not going to look at. And I think I need to sort of demonstrate this now. Rosie, have we got the actual Excel spreadsheet available?
We do. Bear with me 1 second.
So I just want to kind of, and Peter will have this, so Peter and Dudley will have this. So this isn't me, I haven't designed this. So Charles Taylor, who I think is from Oxford Care Association, or Taylor and Taylor sort of care homes, his staff kind of like came up with this. And for me, and I mean, obviously you don't have to do it, but I think it gives you a bit of an idea about why all this talk about quality statements is an issue. I'm going to talk to you, and I'll try and whip it together in about 30 minutes. But what I'm going to try and tell you is what the issues still are. So don't change anything that you're doing, because the issues in the most recent reports I've looked at are the same as the ones that I'm going to show you in a minute. But first of all, this spreadsheet, what's it about? What you're trying to do? So all it is trying to sort of work out what your current rating is. And basically, in terms of quality statements, when they look at quality statements, what it needs to be in order for you to improve your rating. And just to kind of like give you a bit of a gauge, there are 34 quality statements. Everything's very complicated. There only used to be 24 Chloe's, but there's 34 quality statements. What has been the problem and the ongoing problem all the time? It's about the fact of inspectors not looking at enough quality statements. So you've still got the 5 key areas. So you've still got safe, effective care and responsive and well led. What I can tell you is the majority of inspections that I've seen and looked at in terms of sort of looking at 50 reports in about the last sort of 3 to 6 months, the actual rating hasn't improved. It's either remained the same or got lower. And the reason for that is not because sometimes standards are going down, it's because they haven't looked at enough quality statements. So I just want to demonstrate just quickly this before we go on to some slides. If you just go down, Rosie, to the bottom. So in that guide there, if you just stop there, brilliant. So the previous inspection rating is what's there. And we'll have a look in a minute about how you get to that. One of the things that I'll point out on this spreadsheet, if you look at the bottom, it says there are 4 exceptions. So when you're scoring it, and it's quite simple, this isn't complex. Basically, you're looking at inadequate's 1, requires improvements score of 2, good is 3, and guess what? Outstanding's 4. Yeah. So that's how it is, apart from those exceptions that are at the bottom about scoring. If we go back up the top again, Rosie. So you can see that those are the quality statements against each of the safe, effective, etc., etc. And what you can do when you look at this is actually score yourself with what your previous inspection is, and then you can see what potentially you would need in order for you to actually improve your rating in terms of scoring. And you can see in this one, even the one that was at the bottom, the score, they've come in and they've looked at these quality statements. So if you look in the second column, if you just go to the bottom, Rosie, we can see how many they've actually done. So in total, they looked at 9. So the difficulty with that is, if you go back up to the top, sorry, Rosie, is that the actual rating hasn't improved. The rating on the top right up there is exactly the same as it was in their previous rating. The reason is because they haven't actually looked at all of the actual quality statements in that particular area of safe or in the area of effective. Because basically what happens is that if you don't look at that area, so if there are 8, and there are 8 quality statements in safe, if you only look at 5, the 3 that are left are actually based on your previous report. Now, let me give you a few statistics which are absolutely, as I said, it's just mind-blowing. The actual current provider ratings are over 3.5 years old. If I tell you that some organisations, social care organisations, haven't been inspected since 2015, that's 9 years old. I mean, some NHS hospitals, it's been 10 years, so that's a worry. But in terms of adult social care, some of you, it's probably, you know, that's probably a reality. You probably haven't been inspected for 5, 6, 7, 8 years. So what's the issue with this? Well, if there are 8 quality statements and you're only looking at 5, they're going to base those other 3 on your previous inspection. So if your previous inspection was good, great. You're going to score a 3 for those. If your previous inspection back in 2016, 2017 requires improvement, you're only going to score a 2. And fundamentally, that's where the issues are, because they need to be looking at, if you requires improvement or inadequate in any of the 5 areas, they need to be looking at the quality statements for all of that particular area, not just looking at some. Because if they're not looking at all of them, they're going to base it on what was happening before. If what was happening before you were good or outstanding, absolutely brilliant. If you requires improvement or inadequate, that's where the real issue is. Because fundamentally, it's making your current actual rating, it will be based on scoring system from a report where you've probably improved immensely, but you're not going to get any credit for it. It's not going to improve your rating. I mean, there are massive other issues in terms of CQC at the moment, including those of you that are trying to register. It's absolutely appalling. I think it's kind of, it used to sort of say on the website 8 to 10 weeks. It's more like sort of 4 to 5 months now, which is affecting, you know, people's, you know, finance and sort of things going forward, which is a real issue in terms of lost revenue and investment and whatever. I think the helpline, if you ring the CQC helpline, the current waiting time is about 25 minutes. I mean, I don't know how long I expect people to sort of hang on before you sort of give up. That spreadsheet, Peter and Dudley will have it available. Please sort of have a go, because it will allow you to sort of know, and I think sort of challenge in a positive way. If we go to the slides, Rosie, you can see a bit further what I'm talking about in terms of, can you flick on to the keep going, keep going, keep going, keep going, keep going, keep going. We're going to flick back and flick forward. Keep going, keep going, keep going, keep going, keep going, keep going, stop. Whoa, that'll do. So look, James Bullion stated this on April 24. So let's have a bit of a what's going on. Ian Trenholm, the chief executive of CQC, left just before the election. Yesterday, Kate Taroney has decided to go. I think, and I don't know, I haven't got any money on this one. I only had money on Kate Taroney leaving before Christmas. James Bullion, I think, will be the chief inspector of adult social care, because it's the job he came in for. And although he's going to be the interim chief executive until Julian Hartley takes over, I think James Bullion will still be the chief inspector of adult social care. So he said in April, he said there, our intention is to review all of the quality statements in a key question. So a key question, safe, effective, caring, responsive, well led. If your previous rating was inadequate or requires improvement. So that's not me saying that. That's what he said. If you go back one slide, Rosie, this is Ian Trenholm. He's left, so it doesn't really matter what he said, but he said exactly the same thing. When carry out an assessment, If it's inadequate, requires improvement, all of the quality statements under that question should be looked at. So what I'm saying to you is these are from leaders of CQC. If someone's basically going to come in and suggest that they're only going to look at 2 or 3 of an area that you have which you know requires improvement or inadequate, they really should be looking at all of it. Otherwise, it's not a fair reflection about what's going on, because they're going to base it on what happened 2, 3, 5, 6 years ago. I hope that makes sense. Right to the beginning then, Rosie, let's have a look at the beginning of the slides, and let's crack through this, because I know time's of an essence. Right, what we're going to do, we're going to look at, I'm sort of in between presentations at the moment, and the reason why I am is obviously who knows what's going on. There's that report from Penny Dash is literally saying almost like an overhaul of what needs to happen, whether inspectors need to do all of the quality statements, make sure they're done, try and recruit more people, trying to make sure that they're specialists about what they're actually doing. What I can tell you is that there seems to be a bit of an improvement. The average quality statements that they seem to be looking at now is about 16. So if you know that there are 8 in safe, 6 in effective, 5 in caring, 7 in responsive, and 8 in well led, things may be improving. But I haven't got definite evidence that that's an absolute in terms of what's going on. So we're going to flick through some of the things that I know are still relevant now, even though these are my slides for this year. Hopefully, we can try and get together and actually be in person or whatever and do one of these together. And hopefully I might be able to get my slides for 2025 kind of like up and running. But I can tell you that what I'm looking at and what I've been looking at don't change what you're doing, because the same issues are still being looked at now as they were in this year and still under the close. So next slide, please, Rosie. So what I do to try and save you guys time and to try and give you some, what I think is if I put it on a slide, hopefully what you'll do is you'll say, oh, look, I won't do that because you saw it on a slide that that's the issue. So we'll make sure we concentrate on it. So good, if that happens, brilliant. In 2021, the top 2 issues were risk assessments and quality assurance. If you flick to the next slide, Rosie, in 2022, quality assurance was still number 3. Medication management came in. Part of that was to do with things like COVID and about the fact of kind of responses, infection control as well. But number 1 was yet again risk assessments. So if we look at what's been going on in this last year, next slide, thank you, Rosie, you can see that still risk assessments and quality assurance are the 2 of the top 10 issues that CQC are finding in their reports. So what does that mean? So in a kind of like cat advert that none of you remember because you're all far too young and beautiful, but there used to be an advert which is 8 out of 10 areas. 8 out of 10 areas relate to safe. So what does that mean? That means that they're in a particular world where they're probably short of experienced staff or short of staff quite desperately, where there's issues around the actual system about what they're doing. They're still looking at fundamentals. And you can see that list on the right-hand side is fundamentally SSSSS. The R is responsive, the E is effective. The WL is obviously well-led. But in terms of things that they're looking at, they're still looking at well-led and safe as being a real area for them to focus on. What are the safety issues and what is, are the management actually aware of those things? Next slide, please, Rosie. Just to flick that into sort of getting away from actual specific subjects, but to look at breaches, because they're the important things in terms of this. Those of you that are in breach of a regulation know that they'll actually do something about that, as opposed to a rating where they probably won't. What's difficult at the moment, and this is an email, this is actually, I mean, in trying to look at the research for doing my presentation for next year, it's really difficult to actually look at a report now and try and find where the breaches are. I mean, I know a little bit, well, I think I know a little bit about CQC, but it's really difficult. Have a look at a recent report and see if you can find easily what the specific breaches are. And I thought it was just me, and I thought perhaps I just don't know what I'm doing. So I decided to, like I do, contacted the help desk to ask them and say, why is it so difficult to try and find breaches in reports now? They came back to me and said, good afternoon, Mick. CQC no longer include the regulations that any breaches relate to. However, if you require this information for any location, then please contact us and we'll be able to provide you with details. Excellent. That basically means that you can kind of like look at a report and it's still difficult to try and find out what the breaches are. What I can tell you from me looking at the most recent ones and what will be in my next presentation for next year is that still Regulation 17 quality assurance and Regulation 12 risk assessments, specifically around risk assessments, is a key area in terms of what they're still looking at right now under the new framework. So don't be sort of bamboozled into thinking you should be looking at something else or that you should be concentrating on something else. The key issue still in current reports are around Regulation 17, Regulation 12. And the top areas that they relate to: quality assurance, risk assessments, medication management. So these things are still kind of like relevant and still live now as they were when it was still the Chloe's, which was the end of sort of last year. And at the bottom there, it just says over 70% of reports have actually got a regulation breach. So out of the 50 reports that I looked at, over 70% have got a Regulation 17 breach. Next slide, please, Rosie. I'm just going to go through some of the things that have cropped up. And as I say, if I show them here, and if I talk to you, hopefully you'll say, well, we don't do that. Don't be silly. It's ridiculous. And that's an obvious one. So environment just came out of the top 10. So one of the things was about the fact, and it is showing in some recent reports as well, is the environment clean? Is it safe? Think about spread of infection. Have you got sort of window restrictors? Are they in place? Make sure those health and safety weekly or monthly trips that you're going around, that those things are sorted out. Next slide, please. Incident accident report. So think about the link to SAFE. If there are incidents and accidents that are not being reported, it's alarm bells for these inspectors, nasty inspectors. Not me, I was nice. Basically, fundamentally, what they're doing is they're saying, if you're not recording your accidents, incidents, what else are you not recording? So in whatever way you do it, whether it's digitally, whether it's on paper, however it is, make sure this happened. This is what we decided to do. This is how it is resolved. In the future, this is what we do to make sure it doesn't happen again. So these comments, by the way, are from the CQC reports. They're not me. I haven't made these up.
This is really good.
Sorry, next slide, please, Rosie. Records. Right, okay. There's a big link in terms of sort of how this is looked at. It's about quality assurance. It's about record keeping. It's about stuff that is conflicting. For me, think about it in a kind of simple way. Care plan. Have you got all the information? Everything that needs to be in there. Next thing is risk assessment. Are there any risks associated with that person? Are those risk assessments up to date? The third thing is about making sure that staff, is there some kind of guidance for staff about what they need to be doing right now? So in other words, of course they can look at the care plan. Of course, risk assessments are boring. No one wants to look through a 20-page risk assessment. What do I need to do right now for me to make sure that my actual support and care for Dudley right now is as it should be? So without being kind of specific about it, don't have a care plan which says one thing, a risk assessment says another thing, and the staff didn't know or they weren't aware of it, because, you know, it will look like it's conflicting or incorrect information. So records, keeping them up to date, making sure the records are up to date, really important. Next slide, Rosie. Digital care systems. I'm not going to talk about digital care. Really important. Pete's mentioned it. Dudley's mentioned it. The guy from the ICS mentioned it. There is a massive agenda for, you know, from government for all care to be kind of like digitized. Great. Other than this is not me making this up. These are direct quotes from CQC reports. Make sure when you're looking at digitizing whatever you're going to do, whether it's an EMAR system, a care planning system, or whatever, that it's better than what you've got. It will be cost effective. It will actually do what it's doing, and it won't kind of upset the apple cart in terms of staff not knowing what to do. Half the records are on paper, half are on the computer, or the computer's not up to date and the paper is, or whatever. Because these are directly from CQC reports that are saying, oh, issues with the provider's IT systems meant the up-to-date information about risk was not always recorded. The last thing you want is to have some sort of digitized system which is actually not beneficial when it comes to your inspection. So think about that in terms of what you're going to get, what you're buying, what you're going to do. Are staff happy about how they're going to do it? Because what you don't want is, you know, conflicting information about on your digital systems. Next slide, Rosie. Right. We're actually in the top 5 now. Number 5, recruitment. I'll say it now. I'm pretty sure I'll say it again next year as well. Really important in terms of what you're doing. And I'm not talking about overseas recruitment here. I'm specifically talking about just recruitment. So on a basic level, there are still issues in terms of recruitment. And it's one of those things, think about it in terms of inspectors. If you're not recruiting safely, that's an issue, because it means fundamentally people are not being checked and given the right check. So a DBS check's being done. Are there gaps in their employment history? Remember Regulation 19, which is all about, you know, fit and proper persons and about whether you've done all the checks. Really key and really important. If your policy says you need 2 references, you need 2 references. And if you've only got 1, a nasty inspector is going to say, well, where's the other reference? If you haven't got it and you can't get it, so for example, I don't know, someone used to work for Woolworths or C&A or Debenhams even. All of these places have gone. If you can't get that reference, or you can't get a reference because someone's left or whatever, get a generic risk assessment, write it up. Peter is brilliant. He's done his training. He's done his induction. No problems with him. He's been working here for like 2 years now. We can't get hold of the reference. He can't get hold of the second reference. We're signing it off as being that's the second reference. You need to kind of make sure that's covered off, or else otherwise someone's going to start picking at it and saying, you've got gaps. Employment history, when you look at Regulation 19, it's full work history. It's not just last year or the last 2 years or what we did for the last 5 years. It's from the time when, you know, you started out from school. That's what the regulation is actually stating, full histories. Just remember that one. Next slide, Rosie. Number 4 is care plans. I'm not going to talk about this very much, other than the fact of what the issue is about the fact that the information is not up to date. So it sort of links in with records. Care plans not up to date, think about safety. So there's a key link in terms of if it's not up to date, if it's not showing the care needed now, that's an issue. Next slide, Rosie. Number 3, I'm not going to go over the top of this, other than mention the one that's sitting there, which is about the fact of any issues regarding individuals that MCA is kind of like relevant to, who may not have capacity. Make sure that you're doing capacity assessments and best interest assessments. I think I've seen it in sort of recent reports as well. It's coming to the fore where people have not, you know, and we all know, I mean, anyone who's got a DOLS application, I mean, half of them are sitting at the local authority, haven't been looked at for years. What I would say is that it's about taking responsibility about what needs to be kind of done in terms of best interest decisions about whatever it might be, whether it's what to wear in the morning, whether it's whether they want to go on holiday, whether it's what they want to do. Make sure that your mental capacity stuff, capacity assessments, best interest decisions are all kind of like sealed and done, and make sure that they're kind of like up to date. If not, there are potentially kind of issues in terms of them being picked up as why is this happening when you haven't got the authority to do it. Next slide, Rosie. Medication management. I keep talking about this, so I'm going to say it yet again. Generally speaking, medication management, not necessarily an issue. The issues that keep coming up are exactly the same, and they have been for some time. So think about stuff like topical medication, stuff where you need a body map. You know, if you've got like a pain patch, have you got a body map where you put it on someone's arm one day, leg next day, whatever? They're being very particular about that, and also about PRN meds. So pro renata for you people that speak Latin, or as required medication. I've got some medication that I need to give someone, but on top of that, if there's a painkiller that you're giving someone, what's the protocols? How often are you going to give that before you actually, you know, contact the GP and see what impact it has on their actual prescribed meds? PRN medication. There are still issues around what that means in terms of if I'm giving additional kind of like medication, I need to make sure there are protocols in place and it's not just an ad hoc thing that happens and nothing's written down, whatever. So make sure you've got that as tight as you can. We seem to be at number one. Quick, next slide, Rosie. And there are two at number one. First one's risk assessments. Risk assessments need more detail. Risk assessments not clear. Fundamentally, it's not about doing a risk assessment for the sake of it. It's about doing risk assessments because it's about mitigating a risk. So you don't just do them for everybody. It's about the fact that when Rosie kind of like started in the care home, she didn't have any mobility issues. 2 years down the line, she has. Therefore, you've probably got to do a full risk assessment if she's falling, if she needs aids in terms of rollators or Zimmer frame or whatever it is, or she needs support by other staff, because these things need to be kept up to date. If they're not up to date, then potentially there's a risk, and that's the safety part that CQC will be looking at. And the final slide then in terms of the top five is this one, quality assurance. I haven't got the answer to this one because basically quality assurance is you actually being in control and understanding everything that's going on, but knowing what you need to improve and what you're doing well. And it's about making sure you're doing audits that mean something. In whatever way you can, you need to be aware of everything that's going on. If we flick on the next slide, Rose, is it about, what's it about? Whoa, what we're going to do here? I just want to quickly mention about the fact that these things are still important in terms of the new framework. Workforce well-being. So anything that you've got in place, like employee assistance programs, any support for staff, still relevant, still really kind of out there in terms of single assessment framework. Middle one, workforce equality, diversity, inclusion. It hasn't gone away. So that's about, and for me, as an ex kind of like equality and diversity manager, that's not just about your staff equality and diversity. That's also about your residents and your clients. What are the things that make them tick? What are the outcomes? What are the things they want to do? I mean, I would suggest that you have kind of like almost like a little separate folder about what great stuff you do in terms of equality and diversity for your staff and for residents, because it's a great thing. Last one of there is learning, improvement, innovation. I mean, they've always had that on CQC radar. What are we doing that's kind of like improving? Those that are outstanding, you think, what on earth can I do now? Next slide, Rosie. Let's see what we got. Environmental sustainability. It hasn't come in yet. I think they're going to start doing it next year. What I would suggest is you start thinking about your environmental sustainability in terms of your service. And even if you've got an A4 page about what you're going to do, if you flip the next slide, Rose, it will give you some sort of, it will give you an idea about some of the things. You know, have you got a policy in place? Are you, I mean, some of these things are a bit ridiculous, especially stuff like imagine people who work in a dom care using their bicycle to, you know, to get to, that's probably not great. The sort of thing I'm thinking about is, you know, get yourself a, you know, a bin in terms of getting your waste, in terms of recycling and other sort of waste. Think about other ways that you can kind of like make sure your environment is as sustainable and you're not doing anything which has got the least amount of sort of carbon footprint impact that you possibly can. Just think about those things, because next year they're probably going to add this to what is going to happen. It's coming from NHS, so it's something that all providers will need to start doing, but not yet. But think about it now, because it's important to do. Next slide, Rosie. Boom, we're getting there. That's just a definition of quality assurance. And as I mentioned, it is literally everything. So what I mean by that is, the CQC are expecting you to continually evaluate, securely maintain complete records, make sure you get feedback from people. With the single assessment framework, it's never been more important for you to get feedback from your staff and from your residents and your clients. And recently, so surveys, make them important. The whole idea of single assessment framework is supposed to be about the fact of, what do people think? So what do residents think? What do, you know, our staff think about the service? Get that information, because that's gold dust. If your staff think it's brilliant, and if your residents and your clients think you're brilliant, then you're probably brilliant. It'll be difficult to sort of counter that with something else that they might find. Next slide, please, Rosie. Boom, we've seen that. He's gone, Ian Trenholm, gone. James Bullion, hopefully he might stay. Next. Right, safety culture. I keep talking about this, so I'm probably boring you, but in terms of when I do prepare my next presentation for next year, which is all about what's happened in terms of the single assessment framework, what they're looking at, it still points towards this. Try and, you know, I haven't invented a safety culture. Even the CQC, if you look at the CQC website, they've even got a section on it. Think about things in terms of safety. Care plan's not up to date, safety. Staff aren't trained, safety. Think about those things because they're the important things that they're going to pick up on. If you think about the areas of focus that they're focusing on in the single assessment framework, they're focusing on these 3 key areas: safe and effective staffing. So recruitment, staffing levels, are staff trained? Second one is involving people to manage risks. That's risk assessments. That's what we've just spoken about. So regulation 12. The last one is safeguarding. They've got a particular thing on safeguarding at the moment because obviously it's to do with safety. If you're not doing those safety reports and you're not making sure the local authority are aware of that, they've got a real issue with it. So without a doubt, it's a definite. Last slide then, please, Rosie. Boom. Those are the things that I want you to kind of like think about, concentrate on. What I will say to you is in terms of preparing for your inspection, make sure you kind of like get some surveys done. How's your feedback sort of being collected? Make sure you've got surveys and up-to-date surveys done. Have you got information from some healthcare professionals that they can write up and say, this is a really good service, they do whatever they are? What things have you actually kind of like got in place? Have you got an action plan about what you intend to do and what you're going to get done? Because the better conversation, particularly around quality assurance, is not, oh yes, and you know what it's like, CQC inspector says, oh, we found that, we found that, we found that. The better conversation is the fact that you know about those things and you're actually going to put things in place to actually mitigate those rather than it being something new. I think I'm sort of out of time purely on the basis that I know that I've gone over time. And I know that was a bit quick, but I'm quite happy to take any questions.
Just before you start, Mick, the slides will be shared on the website.
Yeah.
And
Yeah.
there will be a recording as well, so you can do. And if we do run out of time, you can leave, I'm sure you can leave Peter and myself or send us a question and we'll try and put it together. I know Mick's forever trying to see what goes on with CQC, and also bear in mind there's lots of changes taking place. But as Pete said before everyone asks any questions, it is down to you, especially the quality assurance side of things. You are responsible, even though Mick has given you some good ideas, thoughts, and what to do. It's down to you doing the work.
Thanks, Mick. Brilliant. I mean, I'm sure we will have some questions. Just a few quick points that have come up with things that we've been doing rather.
Yeah.
If as a provider you've got an ISO standard, it helps. So if you haven't got an ISO standard, then it's something very much worth looking about getting them for the future of your business. It certainly helps. Mick mentioned in a slide, Mental Capacity Act. We've seen some local authorities talking about the replacement for those liberty protection standards, which we've no idea when they're coming in. So don't buy any training. If anyone talks to you about whatever it is, LPS training, they're conning you. Don't do it. Workforce wellbeing, the links to equality, diversity, inclusion, and innovation in the workplace are all parts of organizational culture. Organizational culture may appear to you as a buzzword or a buzz phrase. It is vitally important. If you have good organizational culture, it works. If you don't have good organizational culture, it doesn't work. And environmental things, we've seen some very, very silly suggestions from local authorities around submissions for tenders, etc. Some of them have an obsessive love for electric bikes. I could be a little prejudiced and say that these people are probably cycling vegans themselves, but it is completely impractical for a dom care operator in 99% of circumstances to operate on a bike or an electric bike. And again, if you're looking to lease electric vehicles, you have to make sure that the lease period ties in with what you're being commissioned to do. And most local authority commissioners have no idea how a business runs, particularly how an SME business runs. Mick, questions? Questions for Mick, please.
It was all too fast and furious, I think. No one could cope with it.
Can't believe we're all stunned into silence.
Yeah, if anyone does think of any questions afterwards, and they probably will do, and saying, oh, why didn't we ask this? And Mick is not CQC, so he won't hurt you, so you can ask a question. But other than that, there are various changes that are taking place. Also as well, audits, and when it comes to a lot of these organizations, we know SMEs, when it comes to looking at things, compliance and making sure your paperwork is in order, this is probably one of the biggest areas to think about. So if you haven't already, I'm not mentioning like anything like Citation, but having someone on board that helps you with this is really important. So do look out for the likes of Citation or any other organization, but let's at least take help with that as well, because CQC will come down very hard. And I know through some of the what Mick has looked through, when people get their ratings, they look about being well led. So please do bear that in mind.
So I think is it Feather? Feather's had a question, where can we get an inspection checklist from? So I mean, it's a really difficult one. I mean, I would say, and I don't know, to be quite honest, Feather, whether you've been inspected or whether you haven't or whatever, I would say continue doing what you're doing. The issue is, and there's actually something going on right now. So there's a CQC sort of event which is happening, which is about developing new ratings and characteristics. One of the problems about the fact of the single assessment framework is they've never actually provided you providers with a guide that says, this is what good looks like, this is what requires improvement looks like, which is something that is they're actually tasked with as one of the things that they need to work on. So exactly that sort of thing, hopefully, might be one of the things, Pfizer, that they're going to start thinking about. So giving you more information about what good looks like, and what, you know, outstanding kind of like looks like, to give you a better idea. But what I would say to all of you, if you can get involved in any of the provider, and I know that Pete and probably Dudley, you know, are part of that as well, contribute to how they decide to mold what the single assessment framework is going to be, because it's really important in terms of getting your, you know, voice across. Because who know, you know, at the moment they sort of know that they've got something that's not working. They need to be told what might work. So be part of the conversation with, you know, Peter and Dudley about what would be good in terms of what that looks like. And then hopefully, Pfizer, we will have potentially kind of like a better sort of list about what things to look at.
Well, surely it's unfair. We're getting assessed against something, and we don't know what we're getting assessed against. And
Exactly
what
right.
statements are they looking for? We should know that, shouldn't they?
Yeah, and I mean, I would suggest to all of you, even if you don't fill out the actual kind of spreadsheet that I've just shown you, go onto the website and have a look at the quality statements. I mean, they've even said themselves that the actual quality statements and what they're asking is quite complicated. But fundamentally, it's almost like just rewording what the Chloe's were. So if you understood what you needed with Chloe's, the quality statements are not a million miles away. So just think about it and continue what you're doing.
Just picking up on what Mick has said and the spreadsheet, that Charles Taylor, who runs a number of care homes in Oxfordshire, he actually by profession is a statistician, and he has done a lot of work in for social care, and that work has been, if you like, seconded. He's been called in to work with the DWP and the DH on various projects. So that type of spreadsheet will be looked at by DH, by CQC. There are various surveys that we've spread about. There's one today about the NHS in the chat. I know you've got little time, but please do contribute. Where you've got issues with the likes of CQC, we meet with CQC. We're part of a national body. Lcas is part of a national body. We have a lot of links, and in fact, one or two of my colleagues or our colleagues have met with James Bullion in the last few days, and there's a number of further meetings. So the points that Mick made are very, very relevant, but sometimes CQC never get any feedback, so they're not going to change. And at the moment, they've had quite a lot of feedback, so I'm pretty sure they know they're not doing a very good job. Margaret, your hand is raised. Fire away, please.
It's actually not a question, just to say we got inspected 2 weeks ago using the single framework. Mick, you are bang on with all that is required. The using the Chloe and all the quality statements. They checked through that, the audits, and checked through the system we're using. We've had an issue with medication on our system. So what we did was, from the previous inspection, we went back to using the paper mark chart and we audit those. And, you know, there was even a question around, so what happens if someone has missed medication? Because you're auditing at the end of the month. But what we've done is we work closely with the carers. We've told them if a colleague has left a blank space they haven't signed, call us, because we need to deal with it immediately because we can't see on screen. And so it's again explaining to the inspectors how we are counteracting anything that would seem as a safety issue.
Excellent.
And also, you know, some of the stuff that we've done in terms of reflection from the previous inspection. I'd worked on reflection as manager to just show that this is what I've learned. And so the comment was, could you then, you know, get your staff to be doing the same, because, you know, they were quite happy with what they saw. So but still waiting for the reporting.
Absolutely brilliant. I mean, the only thing, Margaret, that I can say in terms of like trying to get a safety culture, because I don't know the answer, because I don't run a care home or a dom care. But what you want is you want everybody, all staff, doesn't matter where they work in your organisation, to make sure you as the manager knows what's going on and what could be improved and what needs to happen. And that's the only way you can do it. Have you heard what your rating is going to be, Margaret?
The feedback was really good, I must admit. So I'm hoping I'm not.
Okay, good. So possibly by next March, you might get the actual rating and the report.
And she did say, she promised in 2 weeks' time. But
2 weeks, right?
Well, the summary, not the full report, just the summary.
I mean, you know,
draft summary.
Okay, I mean, always be positive about it until you get the result you want. What I would say in terms of the issues about ringing the helpline, or if you're, you know, registering and whatever, give them tiny little kind of occasional kicks. You know, please, are you looking at my registration yet? Please, can you answer my query or whatever? Just nice little gentle knocks to kind of prompt them to get you to the top of the pile, because I think the pile is so high, people are just not being dealt with in any particular way. So it's good to hear that it's gone well so far. I'm fingers crossed for you.
Yeah, even the inspection itself, it took 3 emails and I don't know how many phone calls I kept saying, because, you know, the rating we had, it meant we couldn't, you know, apply to some of the tenders.
Right, okay.
And so just kept banging in, sending in emails. And so when they came and they said, well, we've come because you requested. But we're talking, you know, the last inspection 2018.
Yeah. And it's a really big thing. And Peter and Dudley will know all about this, but I'm not quoting myself. This is quoting from the report, from the Penny Dash report. The review heard that the backlog in registrations was a particular problem for small providers trying to set up a new care home or new healthcare service, and could result in lost revenues and investment, which had a knock-on impact on capacity. So I would always go for the fact that the CQC, so you as an organisation, are stopping me actually providing a service and care, and it's affecting my bottom line in terms of money. So I would always use that as a kind of, if you don't come and do an inspection, it's going to impact my ability to get tenders from a local authority.
That's exactly what I did. The last email I sent was to just break down how it had impacted on our business and show how we'd lost a number of clients and the impact on the carers, and how we couldn't then, you know, live up to giving them living wage and whatnot, and then the knock-on effect on staff in the office.
Yeah,
brilliant. Well, that's the way to do it.
Yeah, a couple of points, Margaret. When you get the draft report, do make sure that nothing has popped up in there that you weren't aware of, because that is a sneaky CQC way of slipping things in that wasn't mentioned at the post CQC inspection meeting.
Sure.
And the other thing is that, Margaret, just something to think about. We've been asked if we could do, say, a meeting a bit like this with providers who've recently gone through an inspection as a bit of advice for other providers who have not had an inspection for a while. And I wonder if you and perhaps a couple of other providers who've recently had inspections will be prepared to sort of, if you like, front up that meeting in a way.
Yes, I'd be happy to.
Okay, great. Thank you. I mean, please do keep in touch, and we'll see if we can find another couple of providers who would come along as well, because that would be very useful, I think, because it's like lived experience.
Yeah.
So we might also, if we can, maybe see if we can borrow Mick in if he's got any time, but he's really informative of this. Thank you for that, Mick. And if anyone wants to be in contact with Mick or Rosie, they've left them information in the chat boxes in the chat as well. So thank you very much. I think time's got the better of us. Just quickly, Peter, just some bits of information. The next managers meeting is going to be the 7th of November. So people should just bear that in mind.
Yeah, the link is in the chat along with the passcode.
And the passcode. And before that as well, we have a Home Office meeting with the Home Office and the DH on sponsored international workforce. The link is in here for you to register. If you can't get through, please send us an email, which should be fine in regards to that. That's happened on the 29th. This coming, I think, Tuesday morning. So please do share, and they will give as much information as possible. Lastly, we spoke about as a whole with London and a big area, we're trying to get Lcas to be a body to be able to influence or work with local authorities, the government, CQC, and so forth. And we'll be probably speaking to you as members to see, we're looking to create a board and actually provide some more professional sort of standing of what Lcas can do as a whole, because this is a real credible group with lots of wonderful individuals like yourselves. We want it to take effect as a whole. So please do look out for some of the information we'll be sharing and asking from you and getting your feedback in the short distant period. Apart from that, Peter, thank you very much for everyone for joining in, and the information will be shared via the website. Please bear in mind, it might be by the end of the week before we get it up, but it will come to you. Peter, thank you.
I'd just like to thank you all for coming. I'd like to thank Mick and the other presenters if they're still here. And I would urge you to take note of what's been said. If you haven't learned something from today's presentation, I'd be very surprised. You always do with Mick. So we look forward to seeing you on later in the month on the international sponsored recruitment one on the 29th with the Home Office. The Home Office, by the way, people are sending us questions to ask the Home Office. The Home Office and the DH are putting together a list of questions and points. Most things they've already heard. It's very difficult to find a new question for the Home Office about sponsored recruits, but they are waiting for that list to be signed off. As soon as it's signed off, they'll let us have it. We will circulate it. Thank you very much for your time. We look forward to seeing you there or on November the 7th. We'll pick up the chat. If there's anything in there that hasn't been followed through, WhatsApp, contacts, etc., then we will do that. Mick and Rosie, thanks again. Great presentation, and we look forward to seeing you all again.
Thank you. Thank you.
Thank you.